the topic, and it's covering for both elderly patients with cognitive disabilities and children with disabilities. It is becoming one of the hot topics in ADC. Is that right? Everybody is aware of, right? Looking at the past papers, some of you are preparing from the last batch, so you have done those questions already. So those who are just starting the ADC journey, and for them, for those which is their first attempt, I want you to know that children with disability, elderly patient with disability, whether it's physical or cognitive, it is extremely hot topic for ADC these days. Yes, does that make sense for everyone? Like those, especially the ones who are taking the exam for the first time. It is still October, so it is officially your first month of preparation. Those who have been preparing prior, or it is second or third attempt for them, they would realize the importance of this topic. But I'm particularly addressing the candidates who have just started their preparation, attempting the March exam. Is anyone there? I need a head count of those. I want to know those people also. Just give me a yes. Those who, for them, for those, it's first attempt. Just started preparing now. Mobarka, you're new. Tuba, Bhargavi, Maria, Jigna, right? Great. Ramona, right? Because what happens is sometimes the names are so common with the previous batches. So sometimes I also get confused and your names are so similar. And sometimes I think, and I don't know, it's the familiarity or what. I feel that you guys have been with me for long, right? And mostly because I've had so many asthmas previously, Mira's also previously, right? And Mubaraka, although I don't think I had anyone by that name, but your name sounds so familiar. I don't know why. So it feels like you probably have been doing. So sometimes I may say stuff like which probably people who have been doing the program in the past, or for them, for those it is second or third attempt, would know it better. But I really particularly want to address the new ones also, right? So because you need to be more aware of the things, because those who are doing second or third, they would be like, yeah, we know this is an important topic. But for you, I want you to know it's an extremely crucial concept, okay? From in the last 1 year, ADC has been really asking on the disabilities and elderly patients, cognitive disabilities, Alzheimer's, dementia. Initially, it used to be dementia and Alzheimer's alone. Now they have broadened the term, and the cognitive disability has come in. Decision making capacity. So, in the last part, we talked about what are the chief problems of these patients, right? The dental pain was one of the chief problems, right? Because the communication is tough. How the team will be involved, how the entire team will work together, the speech therapist and the behavioral therapist, how they will work together. And oral hygiene is a challenge here. So we talked about preventing the diseases in these patients, risk factors, what were their own personal risk factors, service providers risk factor, caregivers risk factor. We talked about all those points. Everyone remembers, right? Now, why is this important? I'm just making this announcement in the beginning. I will also announce in the end and reiterate you. In the last class also, I told you guys, remember, I am going to give you a November public mock, which is coming on this Saturday, right? Which is in few days only. Tuesday it is now. So Saturday is the 1st November. So Saturday is your November public mock. Yes? So what is the topic for November public mock? First time we're doing the topic oriented mock, so that the entire in-depth of the topic gets covered and prepared. So the topic includes cognitive disabilities, children with disabilities, and child dental benefit scheme. So what is the syllabus for this mock? These two classes, the ETG 2 classes, right, of the cognitive disability chapter, which first part we did last week and second part we are doing today. Other than that, the other subject, the other topic is children with disability. Now, is there a class on that? Yes, let me show you that on the app. It is also on, I don't know if it's available on Facebook anymore or not, but we have added it to the YouTube channel if it's not on Facebook yet. If we have in Facebook, then it's fine. If we don't, we have it on the app also. With disability, let me show you in the archive. It's added to the app, right? As well. Wait, let me check on the study plan which week it would be. In the pedo week, it should be in the week 3 or 4 pedo week. And then on pedo. Oral health and disability in children, it's added to, wait, this, which week is this on? Week 7, day 3. All right, let me check on the plan. Yeah. Let me share my screen again. So for those who are enrolled with us, it's on the app on week 7, day 3. Right? If you go on the week 7, day 3, it is given in the day 3, oral health and disability in children. So for Saturday mock that you will be taking, the November public mock, you will watch 2 eTG cognitive disability classes, and you'll watch this oral health and disability in children class, and you will read the ADA health policy on child dental benefits scheme. The policy is also given on the drive entirely. If you don't want to read entire policy, it's given on your hot notes of health promotion. So when you go to the Winspert Smart Docs, and you have health promotion hot notes as well, right? So in those hot notes, health promotion hot notes, you have your ADA policies summary. And in that, you have child dental benefits scheme also. Now, those who are not enrolled with us, you can get the policy on our free program, a free mentorship program on our app. So you can message us and you can get the material there. Right? So on the ADA policies, you have the child dental benefit scheme policy also summarized here. So these 3 are the syllabus for this week's mock, okay? eTG cognitive disability chapter, children with disability, and then your child dental benefit scheme. Clear for everyone, the syllabus? I will make an announcement also tomorrow on the Facebook group. If you read only hot notes of policy, it would be enough. Yes, Tanvi. Because in the policies summary also, we have added all the relevant information. It would be number of the policy, I don't remember, but you just check it. You'll find it here. All right? All right. So let's start with today's discussion. Yes, VD, I'll announce the entire syllabus also on the WhatsApp group and also on the Facebook group. 2 classes of eTG on the app, Namrata, we'll add today. Okay, so you will prepare from the app. Under the live classes public section, so there is a live class section, right, Namrata? For the live class of March 26 classes, under that, for the live weekly class, we'll add it. Okay? All right. So now let's start talking about, we left off at obtaining the consent for such patients, right? So now we know that the Pain calibration is difficult. Diagnosing the pain is difficult in such patients. It is hard to assess pain. The oral hygiene maintenance is tough. There are risk factors which are involved. So these are patients which require special considerations. But yes, the specialists need dentistry. They are also not easily accessible. That's why the general dentists need to be fully prepared, right? Now, obtaining the consent is extremely important, but yet challenging in such patients. Why? Because you first have to assess and know that whether they have the capacity to give the consent, right? Because cognitive disabilities can be different, and even on days and even on the particular day, particular time, the capacity for such patients changes. Sometimes they can be especially Alzheimer patients, sometimes they remember stuff, sometimes they don't. Even in dementia, they can have periods and episodes. So even with cognitive disability patients, they can have time, they can have days on which they may have the capacity or they don't. There is no black and white to tell when they have the capacity or whether they have the capacity or not. It is like a subjective assessment which a dentist would know. And if you're not a long-term dentist of that patient, if you've not been treating that patient longitudinally from a very long time, alone it would be very hard for you, right? That is why you will have to involve their family members, their carers, to assess that whether they are in the capacity or not. Is that making sense? Yes, that if you're not longitudinally treating them, in that case you will consider taking advice from multiple sources to assess the patient's capacity. Okay, but even if they lack the capacity, still you should tell them that this is what we are doing, this is what we are planning. Do you want to be done? Do you want this to be done? So, still involving them in treatment planning, asking their views and wishes is the basic respect that you have to give them. It is mandatory to involve them even when they lack the capacity. Does that make sense? Because in the exam, they could give you this question: the patient doesn't have cognitive disability. Would you still consider their views and wishes? Would you still obtain their views and wishes? It is not optional. ETG says it is must. Their views and wishes must still be obtained to inform any treatment. Does that make sense for everyone? Yes or no? Number one learning point in the consent obtaining. First, you gauge their capacity. Capacity can be gauged. Capacity can change over days, period of days, sickness, health. And if you are not longitudinally involved with that patient, you might have to take advice from their family members or their, carers, because you will not take that judgment alone. It is a very subjective thing. There is no hard and fast rule. There is no particular indicator of it, right? That is why supported decision making, you will still educate them, you will still involve them, and obtaining their views and wishes is a must still. Yes, if they don't want to talk, they don't say anything, Mubaraka, then obviously family, somebody else is giving, the substitute decision maker will give the consent, right, Mubaraka? When they don't have the capacity, the substitute decision maker will give the consent. But even if substitute decision maker is giving the consent, you must ask the patient's views and wishes. Even when they don't have capacity, even when they're not giving consent, the wishes and the views are to be obtained, and they should be informed of the treatment still. Does that make sense or not? That is one step. Who gives consent? Yes, substitute decision maker does. But do you still obtain the patient who doesn't have the capacity? Do you still inform them of the treatment entirely? Do you still ask what do they wish, even if they don't have mental capacity? What is the answer now? Tell me. That's the concept. That is one thing which you can go wrong on if you don't. Yes, Mubarak, answer to that is yes. If the patient doesn't have mental capacity, do you still then tell them the treatment? Yes. Do you still ask them what are their wishes? What treatment do they want? Yes, they are not giving legal consent, but you must tell them and you must obtain their wishes in whatever language, in whatever way they can tell. Maybe they can just nod. It is a basic human respect that you're giving them. It is mandatory from your side to give them. Now understood? Mubaraka. Okay? Even when a person is considered to lack capacity, I'm quoting TG here directly so that nobody makes any mistake here. If patient does not agree, and if you think that is in favor of the patient only, you will have to acknowledge and consider the patient's wishes still. Yes, Prakshi. Yes, exactly. That is why you're asking them. Because when you ask somebody's wishes, that means you wanna, they have the room at the table, right? They have the say. They may not be giving the legal consent, but their wishes matter. It should not ultimately harm them. It should not be like completely against your plan. Then you have to see what is ultimately for the bigger benefit, right? It should not be an unrealistic. But if it's between, implant or something and they say, or surgery or something, and they say no, then you have to respect it. Okay? That is between the family member and the patient. Yes, there has, if the substitute decision makers and the patient's decisions are not matching, are not agreeing, then yes, that will require some kinds of discussions. Okay? And convincing. Right, Tanveer? So it would not be straightforward. Understood? Right? So I'm quoting eTG again. Even when a person is considered to lack capacity for a particular decision, their views and wishes must still be obtained to inform any treatment, intervention, or testing. Right? So when the person does not have the capacity, then who gives the consent? Number one is your substitute decision maker. And if the substitute decision maker is not present, then the appointed legal guardian. Asthma, ultimately, the treatment that should be done for the patient should be for the benefit of the patient. If the patient refuses a treatment which ultimately does him a lot of harm, in that case, substitute decision makers will be followed. Your own clinical judgment will also supersede that. And asthma, you've enrolled, right? So I've done this chapter, this ADJ article, medical legal aspects of dental treatment of the aging and the aged patients. In this one, they talk about patients who lack the capacity to give consent. What should be managed? Who should give the consent and how it should be managed? And in this one, it is example has been given of a legal case where the patient was not agreeing to a procedure which was for the benefit. In which week is this article? This must be in the old medicine week. If I look at the plan, medical legal, this is either under some CV class or some special topic class. Just check there, Tanveer, on the CV classes. You haven't reached that stage yet, I guess. If it is not a standalone class, yeah, I'm coming to that, Sufia. Medical legal considerations in aged population, it is given as a hot note, but I have also covered it as a class for sure. In one of the classes, it is this article is covered in one of the CV. Oh, perfect. Charu told you. So it is clinical and medical legal consideration endo. That's separate. That's endodontics only. In CV 11, Charu, yes, because I remembered it's either CV or a special topic class. Beautiful, Jita. Thank you. So this is yes in your CV 11. Okay. So this article is extremely important again. And let me show you. So substitute decision maker is somebody who will take and give the consent on the behalf of the patient who doesn't have the capacity to give consent. Understood? Somebody asked me about the definition of substitute. Sufia, it's clear now? What is a substitute decision maker? In an incompetent adult who is not able to give or doesn't have the capacity to give consent. The article title is also given on the in the drive, Tanveer. The article is also in the drive, in the oral medicine folder. Okay. So in those patients, the nearest relative is the first available person on a prioritized list who's willing to undertake the task. Now, this is the descending order of the substitute decision maker. The spouse comes first, then the children, then their parents, then their siblings, then the grandparents, and then grandchildren, then uncle and aunts, and then nephews and nieces. This is one of the states' descending order of preference of substitute decision maker. Right? This is the sequence. And if any of these are not available, if the next of the kin are not available, when the patient who's lacking the capacity, when he had the capacity, either he would have appointed somebody, a power of attorney or a legal guardian, before the condition happened to them, then that legal guardian. And if they did not appoint anyone as a legal guardian, then court can also appoint them a legal guardian. Somebody who does not have any kin, next of kin, and they also do not appoint anyone as their legal guardian, then court can also appoint their legal guardian. So if the next of kin or the substitute decision makers are not available, then the second best is legal guardian. So when both the options are given, if a patient lacks the capacity to give consent, who will give? Substitute decision maker, which is the family member, versus legal guardian. What is the priority? The priority is, no, Charu, first is your nearest relative. Okay? Right, Charu? So first is your substitute decision maker, which is your nearest relative. And then if none of them are available, then appointed guardian. That's the sequence. Will everyone remember that? Yes or no's, please. Is that clear for everyone? Again, important learning points. Yes? Wonderful. Now, capacities, suppose one day your patient had the capacity, you assess that he has the capacity, he has a cognitive disability, but that day he had the capacity, you obtain the consent. But now in a recall appointment and you're planning to do another treatment, and that day you don't know whether the patient has the capacity or not. That's why in every appointment before any procedure, capacity should be reassessed because it can change over time. As there is no standard tool, that is why you will take each person's situation individually and assess them. Okay? So you will, so what gives you the complete information that yes, this patient is eligible to give the consent is that they should be able to receive your information, comprehend it, retain it, and recall it. They should also know that this information, how it fits to their situation. They should know the harms and the benefits of the procedure. They should be able to select the options amongst the given treatment options, and they should also be able to convince and justify why they are choosing that particular treatment. And they should be able to communicate to you what is their treatment of choice. Exactly. That is why, Tanveer, if the patient's consent and capacity changes, right? Then before any procedure, you have to reassess their capacity. No treatment you will start by obtaining consent. Either the patient gives only if he has the capacity. If he doesn't have the capacity, then definitely the substitute decision maker will give. Okay? And sometimes you must also see when the substitute decision maker is giving the consent, you know they mostly will be family members. So you should also pay attention and be aware of the dynamics, the family dynamics. Does that play a role? The coercion, the forcing, especially on a person who has cognitive disability and lacks their own decision making capacity and who are dependent on the family member. Sometimes they have the ability to provide their views and wishes, but their family members can be coercing them because of the cost, because of the time involved, or something. Maybe the disability patient wants the best treatment for them and says, I want implants, yes, but the family member says out of cost or something or whatever, because of the, that they don't want to maintain or something, they will not acknowledge the patient's respect, their patient's views. That can happen, right, in interpersonal family dynamics. So the power imbalance also can play a role here. As a professional, is it your responsibility to be aware of that, or you just ignore it? Oh, it's family drama, let's ignore it. Tell me. As a professional, healthcare professional, is it important for you to protect the wishes and rights of your patient, whether or not they have the capacity to give consent or not? Their wishes and views should be respected or not? Exactly. So if the substitute decision maker is denying it on wrong reasons, right? See, finances is, of course, informed financial consent is also obtained. So if finances are the reason, you will still understand, right, Tanvir? Because, of course, the patient may not be the one who's paying. The family member could be the one who's paying. In that case, the financial consent belongs to the family member. Is that right or wrong? So if the patient's wishes is yes, give me the most expensive denture, most expensive material, and the financial consent and the finances are coming from the family member, yeah, then definitely you will respect the family member's decision of going for a cheaper option or a cost-effective treatment plan, right? Because patient is not paying. Somebody who's paying, their financial consent is coming. Agreed? Does that make sense? Is the example coming along or not? And this is given to you in SBQs. Anyone remember Antonio's SBQs in UF1? Anyone? With the daughter, Antonio, the daughter was busy with her job and the language problem was there. The similar power play and the financial, the family dynamics was going on in that SBQ. Remember? So ADC does give you family dynamics, power play, power imbalance between family members, right? Yes, the translator was the problem, Ramona. The language was a problem, but there was definitely a power imbalance problem as well. That is why when you asked the daughter to step out and you wanted the consent to come directly from Antonio, because he had the language barrier but not capacity problem. But imagine now the same situation. I'm giving you a hypothetical situation here. Imagine Antonio had a cognitive disability. In that case, still his wishes should be respected. But if finances are coming from the daughter and Antonio is not paying for himself, yes, financial wise, you can consider the daughter's request. But just because she says, oh, she doesn't have the time to come for the treatment, that does not call for to disrespect Antonio's wishes. Does that make sense? Because financial consent, yes, because if somebody doesn't have the finances to pay for the treatment, we do choose cost effective treatment options. But just because she thinks that I cannot bring him, I don't have time, that is an abuse. That is a neglect. Neglect is a kind of abuse, right? If they are the primary caregiver and not bringing them for the treatment, for parents for their children and for children for their elderly parents, if they are responsible to maintain their health, and if they are not bringing them for the treatment, it's neglect. See, Zoom, if they cannot bring the patient to the clinic, then they should appoint someone, right, a caregiver and all. So these populations are all also highly vulnerable for abuse and neglect. This is also in one of the policies and articles. Asta, Substitute decision maker is spouse. So next of family, next of kin, that is preferred over legal guardian. Legal guardian only comes in place when no next of kin is available, Asta. Got that? Well, you only MS, you don't immediately report it as neglect. Initially, you intervene and try to avoid it. But if they are completely neglecting and not bringing, and you see certain emotional abuse or neglect, then to an extent, after certain extent, you will have to report it. We have an ADA health policy on that as well, MS, and it has been added to the hot notes also. Slowly, you will get there. There are authorities, Tanveer. So you would get their authorities numbers from your clinic. There you have to report. Okay? The patient has cognitive disability and substitute decision maker is denying the patient's wishes. On what behalf are they denying? That has to be assessed. It cannot be denying on the behalf of just they can't comply, or they don't want to come and bring the patients for those appointments. If it's because of the finance, and if the substitute decision maker is the one paying, then you will have to accept it, because if the substitute decision maker doesn't have the money to afford the treatment, you can't give expensive treatment even if the patient wishes. Whoever's paying, financial consent only has to come from them. Understood? If the patient is wealthy and patient is paying, then of course, and then if the substitute maker, decision maker is saying, no, no, I want to keep all that money, that's wrong then, right? So financial consent comes from the fact who is paying. It is given, it's also covered here. Financial consent is important. It will be separately obtained other than informed consent, right? But it has to come from the person who is paying for the treatment. Okay. And sometimes informed consent may be coming from the next of kin, but the financial consent can be coming from a different individual or authority. Okay. Sometimes informed consent and financial consent can be obtained from separate individuals. Maybe the person with the cognitive disability has given his money, or somebody else or some authority is handling their money, and the next of the family member only can give you informed consent for the treatment, but the financial consent may be coming from a separate individual or separate authority. It is an ETG concept. Yes. And in cognitive disability patient, Tanveer, it may come from different people or different authorities. Understood? Everybody understood that in cognitive disability patients, financial consent and informed consent may be coming from different individuals or authority. Which question, Charu? Sorry, let me. According to ADA policy, the order is legal advice directive, legal guardian, and then family. No, in case of cognitive disability patients, I showed you this article as well, no? So this is, yeah, advanced directive. That means if the patient has given any will or any advanced directive he has given, that's the first. Or he has a court or guardianship authority appointed prior. If he has a legal guardian appointed for guardians are the persons appointed by a court or tribunal to make decisions on behalf of an incompetent adult. So wait a second, there is some internet connection. Is it okay? Yeah. See, if the patient has already appointed a legal guardian, if the patient before the condition had already appointed a legal guardian, then yes, he would come first. But if there is no legal guardian appointed and the patient comes up to you, there is no advance directive or the patient has no appointed legal guardian, then in that case, family comes first. Okay? If the patient himself has appointed a power of attorney or legal guardian, then only that legal guardian will give the consent if the patient has already appointed them. Okay? Now, in these patients, the financial consent and informed consent can come from separate people. All right. So, in this case, legal guardian, also you need to check whether the legal guardian has only been given to give informed consent or also managing their finances. That is all the in-depth questions you will have to ask the family members, you will have to ask the legal guardians, and then only the consents will be obtained. That is why in cognitive disability, obtaining consent is a big deal. And there is entire medico-legal process behind it. Okay? Clear for everyone? So financial also can come from separate people. For financial also you will have to check who has the authority to sanction the finances for the treatment. They will give the financial consent. Now, sometimes a family member can also hire people for like a paid caregivers. Is that right? Some families can appoint paid support givers to such patients. Those paid support people or paid support workers cannot consent to the treatment. They will never be considered as part of the substitute decision maker. So only family members, legal guardians, or if the patient has given any advance directive. I think the financial one is not separately given here, Suyesh. So far as I remember, this is additionally being given in eTG only. Because in this article, I did not read about it. And I remember when I teach an article, I always remember, but in this article, see, no. So financial consent concept is not covered in under this article, but thank God for ETG, they have covered it in that. And when I make the hot notes on the ETG, I will add that information there. But ETG has very clearly mentioned it that the financial consent and informed consent can be coming from separate individuals and separate authorities. Okay? Clear for everyone? So understood everyone, the consent obtaining, all the challenges, who is responsible, who will give, substitute decision makers, legal, patient's own wishes and patient's own desires, financial consents, informed consents, patient's own capacity changes with days and times, everything. Understood? Yes, there are program fundings as well. Yes, absolutely. So the schemes should be available, the disability schemes should be available and should be informed to the patients. Okay. Now, what are the challenges with these patients? They have dental caries, high prevalence of dental caries, then high prevalence of dental erosion, periodontal disease, malocclusions. They will be highly anxious also, and sedation when what to prefer for them, what should be the modalities, the pharmacological modalities, and what is your role in providing them the care, especially when managing the anxiety and the sedation. Okay, so let's talk about these now. What are the conditions and what is your role in preventing them? So these patients could be on multiple drugs, right, and could be multiple medical conditions also undergoing. So they could have high sugar intake, The sugar could be also part of some of the syrups or the medication that they are taking. The poor oral hygiene is also a challenge. They could have dry mouth, age-related dry mouth, drugs-related dry mouth. So that is why the prevention would be advising them the fluoride toothpastes, fluoride varnishes, diet counseling of their care providers, right? So definitely the caries risk would be higher. You will categorize them as high caries risk, and then from the TG alone, from the fluoride table, fluoride varnish, fluoride toothpaste, the strength and the varnishes frequency and the diet counseling, you will apply for the same high caries risk. And the treatment preferred for cognitive disabilities, the simpler treatments are preferred which require minimal intervention. What is the best procedure for the elderly patients, especially with cognitive disability and with children with cognitive disability for caries? Absolutely smart answer. SMART, STF related atraumatic restorative treatment, right? So silver diamine fluoride, smart technique will be done and preferred. Now, in the article of geriatric oral health, I've covered that. Yes? In the geriatric oral health, we have covered that. There is a class on that as well, added to your study plan. And the entire technique, method, success rate has been covered there. It is in one of the weeks. Geriatric would be in the oral medicine, I guess. Residential care and geriatric oral health. This one. Yeah, the same week 7 only. Okay. In this case, first you do STF, Shraddha. Over that, you can do GIC also in this layered technique. But otherwise, if you're preferring GIC versus STF, then STF is preferred. And there is a two-step technique also, which includes both STF and GIC, which counteracts the darkness and the blackness of STF and gives you the aesthetics or tooth-colored or white restoration of GIC also. Tanveer, I've explained the entire procedure because that would require at least 30 minutes, that explanation of that procedure. It is covered in residential care and geriatric oral health. You can see on my screen. Yes, it's under week 7. I've covered the entire Australian article. This is the latest Australian recommendations of using the silver diamine material for management of caries in geriatric and patients who are in residential care. Yes, on the day 4, week 7. Okay. Even on the corneal caries, Shraddha. Even in the root caries also, corneal caries also, STF, because it leads to, see, RMGIC requires you to remove the caries first. Why you do atraumatic? Why do you do smart? Why do you do atraumatic restorative techniques? Because these patients cannot withstand long appointments, and the noises and the drill, the sounds, they can irritate those patients. That's why the atraumatic restorative technique. RMGIC is your conventional material that requires you to prepare the cavity, right, Shraddha? That is why composite RMGIC you're not choosing. They are not atraumatic restorative techniques. They require full cavity preparation. Earlier, ART or the atraumatic restorative technique meant by spoon excavators and your hand instruments, you will excavate the soft caries and put GIC. It will arrest the remaining caries. But more than GIC, it's the STF, which is a superior material in arresting the caries. But the drawback is that it makes the tooth dark. But that is to combat that, there is a two-step technique. So you don't even have to remove the caries. You directly put the STF, right? And then on top of that, you put the GIC. So blackness is also counteracted and you don't even have to use the hand instruments and the entire existing caries gets arrested. Is that clear now? Tanveer, Shraddha? Perfect. In week 7, under that geriatric article, you will learn more about in depth of that complete procedure. And even in the Mega Master file and Ultimate Advanced file, there is a patient of the Alzheimer patients, right? Living in the residential care facility. In that, ART also I've discussed with the Adelaide University article of ART technique. Everything is covered, one place at a time, everything is covered. But it at one place to cover everything gets difficult, right? But when you do the program entirely, all the articles have covered, all the techniques have been covered and applied to the SBQs directly. Now, erosion also is really prevalent in such patients. They would have mostly because of the GERD. These patients have high incidence of GERD. So they have intrinsic erosions, the vomitings and acidic medications, dietary acids, acid reflux. It all can lead to the erosion. So again, the prevention is sodium bicarbonate mouthwashes, rinses with waters, rinses with fluoride varnishes. Just like your standard erosion prevention and management, we have done that, right? Avoiding brushing immediately after vomiting. Yes, also you could investigate further, not always, but it should at least link when other symptoms are also present, Charmi. Then give them saliva substitutes, remineralizing agents, fluoride again, CPP, ACP, dietary counseling, and medication review. So management is same as for your other patients of erosion. But just you have to be aware that these are the common findings in these patients. Now, periodontal disease is also highly likely one because the oral hygiene is poor, oral hygiene maintenance is poor, and also some of the conditions like Down syndrome genetically make such patients prone to excessive periodontal breakdown. Is that right? Down syndrome is associated with an additional risk factor, right? The neutropenia, T cell dysfunction, which leads to excessive periodontal destruction. So, periodontal disease comes with that. Rapidly advancing periodontal destruction is seen with them. And in general, also, they have the risk of poor oral hygiene. Then, certain patients with such disabilities also have epilepsy. So, anti epilepsy, anticonvulsant drugs also lead to what? Gingival enlargement. That also becomes a plaque retentive site. Agreed? So again, oral hygiene maintenance, prevention, regular maintenance of scaling and polishing, educating their caregivers, assisted brushing and flossing aids. We talked about the brushing also, wider handle, three-sided brushes, toothbrushes, and electric toothbrushes. Then chlorhexidine gels or rinses, but should be supervised, and also regular recall to maintain their oral hygiene and periodontal health. Other than that, these patients are also at risk of developing malocclusions because they have oromotor dysfunctions, abnormal muscle tone, abnormal habits, growth disturbances. They all can lead to dental malocclusion. If these disabilities are seen in children, orthodontic intervention must be done timely. Sometimes in some patients, conventional ortho can be done, but in some patients, appliances can be challenging, especially the removable ones. So that is why an orthodontic and a specialist need dentist involvement would be required to assess their orthodontic needs. Habitizations, oromotor exercises, all and then speech and swallowing and chewing. So it would require speech therapist, behavior therapist, orthodontists, and special need dentists. Agreed? It would be a multidisciplinary management of young patients, young children with disability who have malocclusions. Understood? Everybody, it would not be a simple you decide and advise and start with your conventional fixed orthodontics. Clear? Does that make sense? Now, dental anxiety, whether the patient has cognitive disability or it's a general population, we have done in the anxiety management latest ETG chapter what is the number one priority, no matter whether mild, moderate, or severe anxiety. The number one approach always has to be the conservative, non pharmacological approach. Yes, Charu, wonderful. Yes, Sonali, beautiful. It has to be the conservative approach. Agreed? So it has to come from initially behavior management, tell, show, do, visual schedules. Mubaraka, I'm saying whether it's the cognitive disability patient or general population with anxiety, whether it's mild, moderate, or severe anxiety, only when the conservative, non pharmacological anxiety management approaches fail, only then you go to the pharmacological management. The first approach is always conservative, non pharmacological, behavioral management techniques. We did that in the anxiety management chapter also in one of the previous week's classes. Remember, Mubaraka? You may need to involve specialists, pediatric dentists, or specialists of special needs dentistry, but the preference should be given to your communication strategies, conservative strategies, rather than jumping to the pharmacological methods. Pharmacological means only should be done when it benefits the patient, not you. You should not try to avoid your challenges by giving the sedation immediately. Sedation should only be chosen when it actually benefits the patient. Like patient cannot control their hands and it can harm the patient. Their anxiety is so severe that they can harm themselves. Then you go to the pharmacological methods and sedation. Understood? Everybody. So, sedation is only given to help the patients tolerate a procedure, not because you want to make it easier for yourself. Your handling has to come from the communication strategies, conservative strategies. Okay? So, you can use nitrous oxide or your BDZs, right? We have done that in the anxiety management class also. IV and GA are only used when the anxiety is severe and would require at least hospitalization or at least daytime admission, right? Trained staff and all. In general dentistry, only your inhalational or oral BDZs can be done. Is that correct? Even the moderate sedation would require a dental board approved dentist. So, as a general dentist, you can only do minimal sedation. Even moderate level of sedation, deeper and higher doses of and deeper depths of your sedation would require dental board registered medical practitioner. And GA is also always medical practitioners, anesthesiologist, and hospital admission. When you're advising them the minimal sedation also, still you will assess for, because these patients have underlying chronic medical conditions. So check for their airway, right? Check for their obstructive sleep apnea. Check for their other medical conditions. Informed consent again would be required. Regular monitoring, right? Caregivers should be present with them. It's difficult for them to also take care of the medication, right? And there can be a problem of fasting times, to take the dose when it is recommended, pre-medication and avoiding food, all that has to be taken care of, and patients with cognitive disabilities can have hard time managing this, and you cannot stand any mistake done by the part of the caregiver, can you? Because they have ongoing cardiovascular conditions, respiratory dysfunctions, so there is risk of aspiration. Their airway anatomy can also be altered. They can have spinal disorders also. They can have liver and kidney dysfunction, so the drug uptake and drug clearance can also be affected. All those factors will have to be considered. These patients will not be straightforward chosen for mild sedation also, because there are challenges greater than the general population. Yes, Tanvi. Yes. Yes to your both questions. Yes. Everybody understood why even minimal sedation is a bigger challenge for cognitive disability patient versus your general population. Why? Because of the underlying medical conditions. Livers and kidneys may be involved, so drug clearance can be affected. Then there can be tolerance to sedative medication because they could be on other antidepressants as well. Even after coming out of minimal sedation in cognitive disability patient, you can have unpredictable and challenging behavior response. Can you or can you not? Yes or no, please? So that is why the pharmacological management of anxiety management, even the mild sedation, is challenging for such patients. That is why it should be carefully discussed with the family members, carers, and the healthcare team. You will involve the specialist in these cases and not do it alone. So specialist discussion and then decision making should be done because of the above said challenges which I told you. Right? So multiple interventions may also be required for such patients, right? And make sure that if you think it's a very challenging situation, it should be done either under the hospital admission or at least day admission. Okay? Some of these patients may also have needle phobias. So in that case also, sometimes GA may only be recommended. So sometimes you think that if it's too much and the anxiety is so severe, even GAs may be advised. That is why the decision making from mild to moderate to completely deep sedation or general anesthesia, the decision making has to come from the multidisciplinary team. It will not be general dentist decision alone. And these questions have been asked. Tardive dyskinesia patient who was on antipsychotics, it's a cognitive disability, right? Somebody who has schizophrenia, somebody who has hallucinations, that's cognitive disability. Yes or no? Remember, it's a mega master file question, MMF question. I don't remember the name of the patient, but he was on antipsychotics, hallucinations, and schizophrenia, and he had tardive dyskinesia and had severe anxiety, and we chose the answer of referral to the specialist for the anxiety management in that case. And he had needle phobia as well. So we could not choose simple minimal sedation because even in minimal sedation, you require local anesthesia. The needles would still be needed. So needle phobia cannot be counteracted with minimal sedation. Yes? Clear for everyone? So Tanveer, the mock would be available on Saturday and Sunday, both the days. If you think you cannot prepare by Saturday, please take it on Sunday. I will have the discussion class on the mock on the next Tuesday, following Tuesday after that mock. Okay? So you will have it for 2 days. So I'm reiterating for everybody who joined in the middle. On the coming weekend, we are having the November public mock. It is entirely free for the entire ADC community. The syllabus is designated to the cognitive disability and children with disability management. It could be cognitive disabilities in elderly. It could be cognitive disabilities in children. It could be children with other health disabilities as well, physical included. So there are 3 classes I want you to prepare for that mock, and one ADA health policy, which is Child Dental Health Benefit Scheme. I want you to prepare this policy and 3 lectures. So cognitive disability chapter has 2 lectures in 2 parts, part 1 and part 2. Today was the second part. Previous part was done last week. And then children with disability is also a free lecture which I conducted. For enrolled candidates, it's under the week 7, day 3. And for free candidates, it's available on Facebook. If it is not, I will be sharing the YouTube link as well. I will publish the entire syllabus, all the classes link, and the policy will also be made available for the free candidates to prepare under our free mentorship program. So if you've not joined the free mentorship program, please join there. And the ADA health policy of child dental benefit scheme would be provided to you on that drive link there. Children with disability, Nikita, is on your, if you're enrolled, then it is on the app. If you're not enrolled, then it's on Facebook and YouTube both. I am not sure about Facebook because what's happening is all the live classes, Facebook removes them after a month. So I have to check whether it's still available or Facebook has already eliminated it or deleted it. I don't know how long ago. I don't think it should be there on Facebook anymore. It was taken a month before. It's been I think in the last batch I took that, so it should not, it I don't think it's there on Facebook anymore. Yeah, because Facebook is automatically deleting a class after a month. The live class, the live lecture goes off, so that's why we publish it on the YouTube. Okay, so I will post all the links that you require to prepare for this mock, and the ADA health policy would be added to the drive link on the free mentorship program. So download the app, get the free mentorship program, and on that drive link, you will get the ADA policy to prepare. Yeah, so that's the syllabus for the upcoming exam. And thank you so much. And I'm sorry if my speed was fluctuating a bit here and there. I was trying to have a grip, but I hope the concepts all made sense. And I answered all your questions in my best capacity. I hope your questions were satisfied, answered, and provided reasonings for. So yeah, that sums up the two-part cognitive disability. For epilepsy, it is not mandatory to do GA. Depends upon the nature of the procedure, how long the procedure is. If there is a multiple appointments needed, then you prefer to do it under GA and doing multiple minimal sedations. Thank you so much, Mubaraka. But I hope everything made sense. All the concepts made sense. That's most important. And see, the good thing that we could link it with the already existing questions, like the Antonio's SBQ, the antipsychotic tardive dyskinesia SBQ. So good thing is that we also already have the real-time examination questions, and we could link with that. And how brilliant of you all to remember those SBQs. That goes out to show so much of your commitment and dedication to the preparation as well. So let me commend you on that. Oh, no, no, no. Cameron is out of my study plan years ago, Tanvir. Because everything that was on Cameron, I have added on the hot notes. Children disability, Tanvir, I have covered from Australian resource. What are the Australian guidelines and, policies around that? There will be 20 to 21 questions, 4 SBQs, Sonali. Okay. So let's meet tomorrow. We have our UF2 internal class tomorrow, and we are going to do next 4 pages of endodontics. After that, on Sunday, you have tutor support class for your hot notes revision in endodontics also. So good thing is that your endodontics hot notes revisions are also going simultaneously while you're doing the UF2 also classes. So similar subject revisions are also going on. And then Monday, as usual, you'll continue to have your therapeutic guideline revision classes with tutors. And bi-weekly on Thursdays, you will get the 3P session. Okay? The 3P session will help you get like a grip of the entire plan, what's going on, what's the purpose, what's the planning that's needed. So it's kind of like a bi-weekly huddle that you will all come together, look at the plan, get some tips and ideas about how to proceed with the program. So those who are joining in between of the program will also get an insight into what's going on, and you all catch up together where everybody is at. Okay, so 3Ps will happen bi-weekly, every second week. Other than that, Monday, Tuesday, Wednesday, and Sunday, you have your usual two tutor support classes and 2 classes with me. Right? All right. So thank you so much, guys, for a wonderful evening together. I hope you learned a lot. And thank you so much. I hope I'm much better tomorrow, because tomorrow we need twice the energy than the article classes. Right? Thank you so much. And I'll see you guys tomorrow. Bye bye. Take care. Thank you so much. See you tomorrow for the UF2 class. Bye.